Welcome back to our NCLEX Army Review. But for those who just joined us today, we are on the 11th day of the 90-day free NCLEX review classes, which we schedule daily at 12 p.m. Eastern Standard Time. And we are covering all the nursing subjects and rationalization of 2000 NCLEX-style questions. And make sure you share this to your friends who are studying for the NCLEX. So we'd really appreciate it if you subscribe and click the notification bell. If you want to know more information about this review, then kindly check the description box below, and we also would love to hear from you. And so if you need clarifications and some questions about the topics discussed here, kindly post your comments. Now, we're also providing the NCLEX course through our website at www.stancoast.nclexcoaching.com, and we want you to avail each topic with straightforward lectures. Now, I want you to challenge yourself with over 3,000 NCLEX-style questions and an additional of 5,000 nursing brainstorming questions. And if you need a quick recap, use our audiobook and also the bullet book for a quick review. And we want to make sure that you prepare thoroughly with 100 hours of dedicated NCLEX preparation. And we want you to explore our collection of on-demand videos for deeper learning and also assess your knowledge with the mock exams and also the test series. And this is something that you will enjoy for about 6 months of access. Now, that will also include about 200 plus of next generation NCLEX questions. And this is something that you can learn at your convenience. So we really want you to consider this course your comprehensive NCLEX preparation solution. Now, today we'll be having the Q&A for the med-surg renal concept. So I want you to sit back and relax. And also we are requesting that you put down your answers in the comments below. So we will be able to track for those who are participating, even though if you're not with us during the live stream, but we encourage you that you put in your answers in the comment box as well. All right, now let's get started with the first question. It says, the nurse is caring for a paraplegic patient who has been diagnosed with kidney stones. The nurse is trying to understand the factors that contributed to the formation of these stones. Now, which factor is likely to have contributed to the development of kidney stones in this patient? Is it A, increased fluid consumption, B, reduced dietary calcium intake, or is it C, decreased kidney function, or D, elevated calcium loss from bones? All right. So here again, the situation. The nurse is caring for a paraplegic patient who has been diagnosed with kidney stones. The nurse is trying to understand the factors that contributed to the formation of these stones. Which factor is likely to have contributed to the development of kidney stones in this patient? Is it A, increased fluid consumption, B, reduced dietary calcium intake, or C, decreased kidney function, or D, elevated calcium loss from bones? I hope that you already picked your answer, because I'm going to start with the rationalization this time. So again, put in your answers in the comment box below or in the live chat. But we really want you to put in your answers in the comments section instead. Now, if you had answered letter A, increased fluid consumption, I'm going to say right now that this is incorrect, because generally increasing the fluid intake can help prevent kidney stones by diluting the urine, and it will reduce the stone formation. All right, please think about that. We already discussed about the renal calculi, and part of the care is to increase the fluid intake. And this is something that we also do for those patients taking the sulfa type of medications. But for this scenario, yeah, this is going to be incorrect. This is not going to cause the development of kidney stones. It's going to do the exact opposite. Now, let's take a look into letter B, reduced dietary calcium intake. Well, it has quite a paradoxical effect here, because low calcium intake can increase the risk of kidney stones by allowing more oxalate to be absorbed and excreted in the urine, where it can form the stones. So this is another option that is incorrect. Marking A and B as incorrect options. Now moving forward with letter C, decreased kidney function. Well, while the kidney function issues can contribute to some renal problems, there's the specific mechanism here, especially with the calcium loss from the bones, is something that is going to be one of the reasons here. And this is because of the lack of mobility. And it's more directly linked to stone formation in paraplegics. And so this is going to be incorrect. All right. Now, moving on to letter D, elevated calcium loss from bones or increased calcium loss from bones. This is going to be attributed to the immobilization, decreased activity, and also disuse syndrome, wherein also the skeletal structures are actually not going to be able to maintain their integrity. So with that immobilization, it can cause the bone resorption. It simply means that this will cause the calcium ions to be released from the bones into the bloodstream, which can really cause these calcium stones to form, right? So we have our answer here, which is letter D, elevated calcium loss from the bones. Now, let's go back to our situation here. We are talking about a patient that has paraplegia. Their mobility is quite compromised, right? They will not be able to really do a whole lot of physical activity that would promote the use of the bone structures, because with the weight bearing, this is actually what's going to prevent the weakening of the bones. If we are using the long bones that we have, let's say the femur or the tibia fibula, when we are ambulating, of course, with the body weight, this can promote the integrity of the bone structure, okay? Now, like I've said, if there is prolonged immobilization, especially with this kind of case, it can lead to what we call as bone resorption. All right, supposing this is going to be our long bone, okay? I'm just gonna make a, I should say probably not the best diagram here, but I'm putting here calcium, which is pretty much deposited into the bone tissue, and we have our bloodstream here. But like I said, in prolonged immobilization, in the case of a patient with paraplegia, with decreased weight-bearing activity, this can cause the calcium ions to migrate from the bone structure into the bloodstream. So the calcium ions will congregate into the bloodstream and eventually will be excreted by the body through the kidneys. So this is going to cause the kidney stones. All right. Now, for the testing, test-taking skills, I really want you to understand the underlying condition. Make sure that you comprehend what the scenario is all about, what paraplegia is, because with that, there is immobility, right? And it can really affect the bone density and can cause increasing calcium level in the blood. Again, in the blood, not in the bones. When there is increasing levels of calcium in the bloodstream, eventually this can get filtered by the kidneys. So there you go. The kidney stones will develop there, of course, with the calcium ions. So again, we are going to use the process of elimination, those options that are less directly related, okay? And so we want to remove all these distractors here, especially increasing fluid consumption. That is not the cause of kidney calculi or renal calculi. That is actually one of the preventive measures in order to flush the renal system, especially the tract. And with letter B as well, reduction of dietary calcium intake. It has the exact opposite, right? It can lead to the formation of calcium stones, and the decreased kidney function is not really going to cause that stone formation. So I hope that you're learning with that first item. Moving on to the next item. What instruction should the nurse include in the patient's teaching plan to manage persistent itching in a patient with chronic kidney disease? Again, what instruction should the nurse include in the patient's teaching plan to manage persistent itching in a patient with chronic kidney disease? Is it A, take regular baths with mild soap, or B, vigorously dry the itchy skin with a towel, or is it C, use alcohol-based moisturizing creams, or D, you're gonna keep the nails short and clean? All right, take your pick. Again, I want you to encourage to put your answers in the comments section instead. All right, and tell us where you're coming from. Your residence, country of residence, or what state you're from. All right, let's go back to the scenario here. What instruction should the nurse include in the patient's teaching plan to manage persistent itching in a patient with chronic kidney disease? Let's go through the options now. Letter A, take regular baths with mild soap. Is this something that could probably prevent any of that? Okay, so let's rationalize. So the regular bathing with a mild soap can help. It can. But it is not as critical as preventing the skin damage from scratching. Now, there's a whole lot much more better intervention aside from letter A. So let's go to letter B. Would that be better option? Now, B says, vigorously dry the itchy skin with a towel. Well, just imagining about it, it's kind of satisfying because of the itchy skin. But eventually this can irritate the skin further, and it's not recommended because the more that they're going to scratch their skin, it can cause skin breakdowns, excoriation, and can be a source of, let's say, or it can also catch some infection. Okay, so those microorganisms can eventually get into those excoriated areas, right? So that would not be a wise instruction. What about letter C? Use alcohol-based moisturizing creams. Now think about the alcohol, the nature of the alcohol rub or the cream. So the alcohol can pretty much dry the skin, and it will also cause exacerbation of the itching. We are eliminating this one. Wow. So we are done with just letter D. We are gonna pick that one, which is to keep the nails short and clean. This is gonna really help prevent the skin damage and also the infection, because of course there's no more sharp edges, of course, with the nails. This is really going to prevent the person from causing any type of scratches or excoriation. Now, selecting letter D, and I really want you to prioritize the preventative measures. So you have to focus on actions that can prevent the complications. Let's say trimming or keeping the nails short and clean. Okay, that's very basic. And again, you have to eliminate those options that can be harmful. So those are your big distractors, such as the vigorous scratching, and also using the alcohol-based cream, right? They are known to be counterproductive, so they can exacerbate the problem. Now let's move on into the next situation here. What is the most frequently observed early sign of kidney disease? Is it A, blood in the urine? Is it B, elevated blood pressure? Or C, excessive thirst and hunger? Or is it D, protein in the urine. Again, the question states, what is the most frequently observed early sign of kidney disease? Is it A, blood in the urine, or B, elevated blood pressure, or is it C, excessive thirst and hunger, and lastly, letter D, protein in the urine? Now, I really want you to go back to what you had learned back in the previous lectures that we have done, especially in the renal nursing. So, I want you to recall the bottom line, early sign in each of those manifestations, especially if there is an impairment in the kidney function. Okay? Earliest sign. All right, let's tackle the first option, A, blood in the urine. I'm going to tell you right now, this is incorrect. This can occur in a kidney disease, but typically it can happen in the later stages. All right. Now, letter B, elevated blood pressure. This is also incorrect. Marking letter A, B is incorrect as well, because the hypertension is actually going to be seen a little bit later. Okay. When there is now a buildup of what? The uremic substances or the nitrogenous waste. That is the thing, or let's say the activation of the RAAS or the RAS mechanism, the renin-angiotensin-aldosterone mechanism. Okay, and this is because of the different issues. It could be that there is the detection, the false detection that the kidneys are not getting sufficient blood supply. So this will trigger the renin to be released by the kidney and eventually will lead into that cascade when the person will end up with hypertension and also the reabsorption of the sodium ions by the kidney tubules. Now let's move on to letter C. What is in letter C? Excessive thirst and hunger. Well, these manifestations are actually more associated with diabetes mellitus, like the polydipsia and polyphagia. All right, so these are not associated with the kidney disease. This is more with diabetes mellitus. Okay. Now let's take a look at letter D. Protein in the urine. Got no other choice, right? This is the early indicator that there is a kidney damage. Okay, and this is when the time when the kidneys normally do not allow significant amounts of protein to pass in the urine. But when this stage occurs, then the kidneys will be losing way too much of the urine. Too much of the protein into the urine. It will allow the protein to leak out. Okay, so this is what we call as the proteinuria. And remember, guys, I mentioned something about that presence of frothy urine. It looks like a foaming coffee, right? It's kind of foamy. So take a look into the bathroom if you are the care provider or the nurse taking care of the patient. So if there's no labs that were drawn yet, there's no medical history of a patient about renal disease, and if you're suspecting that they probably are developing into the kidney disease, that frothiness or that that kind of a bubbly, which is probably bubbly, yeah, just frothy. So that would really indicate that there is a high levels of protein in the urine. So that would give you that clue. All right. So our answer here is protein in the urine. This is the early sign of kidney disease. Okay, please remember this one. Early sign of kidney. Now, for the test taking strategies, you have to recall in the pathophysiology about the earliest detectable sign. Again, look for that option that represents a primary, an early indicator of the kidney dysfunction. And also, you're going to need to eliminate those less specific symptoms. Let's say blood in the urine, because blood in the urine can also develop in some other disease or disorders. And also with the elevation of the blood pressure. Again, this is going to happen in the later stage, right? Okay. Now, also can be related to other conditions. So this is not really an isolate. It's not really the main what do you call this manifestation for this disease. Okay, it can be attributed to other conditions as well. Now we have to go into the next item here. We are gonna have question number 4. In the care of a patient following prostate surgery, which complication requires immediate assessment? Again, in the care of a patient following prostate surgery, which complication requires immediate assessment? Is it A, early signs of lung infection, B, signs of severe bleeding, or C, symptoms of urine retention, or D, signs of blood clots in the leg? Take your pick. We are talking about a patient after having a prostate surgery, and we are being asked about the complications that or complication that will require your immediate assessment that you need to investigate. Is it A, early signs of lung infection? What do you think about that? Well, this is something that could be considered as important, but not immediately life-threatening compared to the other options that I will be revealing soon. And so we're going to eliminate this option A. Okay? Usually it's not the lung infection that we're really going to anticipate at this time. There is much more priority, especially with a prostatic type of surgery, because this is a bleeder surgical procedure. Now, what about letter B? Signs of severe bleeding. Well, I gave you the clue. This is the correct answer because of the vascularity of the prostate. The patient can be really at risk to developing the hemorrhage, and this can also cause rapid deterioration, especially if there is massive blood loss. And we really need to pay attention to stopping the bleeding and also making sure that the hemodynamics of our patient is stabilized. Okay, we are gonna select letter B, right? Again, high vascularity of the prostate. It's a smooth muscle, guys. It has so many blood vessels in it. So if you're gonna think about an organ, let's say prostate, bladder, any of those smooth muscles are very vascular. Uterus, smooth muscles. There's so many networks of blood vessels there: artery, arterioles, veins, venules, capillaries. So once there is an incision done for the surgery, think about the bleeding as our highest complication. All right. Now take a look into letter C, symptoms of urine retention. Well, this is something that can also require attention, but it's not as urgent compared to our letter B, which is bleeding. Okay? Because, guys, when we are talking about the bleeding, not just like a drop of blood, right? When I'm talking about bleeding, there is probably passage of the blood, or let's say oozing of blood from the incisional site, or it could be there is presence of blood clots in the urinary tract, especially even if they have the continuous bladder irrigation. You really have to pay attention about the color of the urine. We really want to make sure that the pink coloration of the urine is maintained in order that we are preventing the blood clots. But if we are noticing that there is continuous redness in the urine, okay, even though you have increased the rate of the flush or the irrigation, then something is not right with the surgical site. There could be disturbance in the suturing of that prostate gland. And so we really need to get the attention of the surgeon when we have done our diligent investigation. All right. So again, letter C is also important, but not as urgent as letter B. That is hemorrhage. Letter D, signs of blood clots in the legs. Well, this is also serious, right? It's associated with the bleeding, but this is not going to be as immediate or as life-threatening as the hemorrhage that we talked about. Okay, so we are going to eliminate letter D, and we are selecting letter B, signs of severe bleeding. Okay, we're talking about prostate surgery. And remember when we had this discussion, most of the different prostatic surgical procedures involve the continuous bladder irrigation. Although some of those other procedures, let's say the laparoscopic, which it did not even include, yeah, we still need to worry about the possibility of bleeding. And so this is going to be our priority nursing care in order that we can detect the massive blood loss and also to prevent other complications such as the blood clots, which can cause obstruction into the urinary tract. Right? Now, the testing tip for you here is to prioritize the life-threatening condition, which is basically the hemorrhage or the bleeding. That can really worsen fast. Okay? So this is something that you need to think about, especially in a post-op or post-surgical case. Think about that highest complication that can easily worsen, and that could lead to more complications if not addressed immediately. Okay. So the other options that we had, again, lung infection, blood clots, urinary retentions, those are also important, but again, these are not as life-threatening compared to the bleeding. All right. Now, also recognize the critical surgical risks, right? So even with the other surgical procedures, also consider about the bleeding as the major risk in the post-op phase. Okay, always do that. Now, moving to the next test, which is, or item, which is a patient with kidney failure needs medication to manage complication. What is the primary purpose of administering polystyrene sulfonate, or known as the dialysis? Repeating the question, a patient with kidney failure needs medication to manage complication. What is the primary purpose of administering polystyrene sulfonate, or known as the dialysis? Okay. Want you to pay attention to the name of the medication. Also, recall onto the renal concepts that we had discussed. Okay, letter A, to correct acid-base balance or imbalances, or B, to swap potassium ions for sodium ions, or is it C, to lower high phosphate levels, or D, to relieve constipation from sorbitol? All right, I hope that you have picked your answer. Letter A, let's take a look. To correct acid-base imbalances. This is incorrect. Why? This is not the purpose of the dialysis, as we know that the dialysis itself, which is a orally given liquid, or it can be administered through an enema or through the nasogastric tube. And the reason that we are giving this, it's because of the high potassium, right? If there is hyperkalemia, we are going to give this medication. And most often, when there is, let's say, maybe a potassium level of 6, maybe greater than that, then the dialysis is ordered to be given orally if the patient is able to do it safely. But if not, it can be administered as through the nasogastric tube or the enema route. Now, again, reviewing about your role here, so make sure you review the level of the patient's potassium level. I want you to make sure you review the chart with the latest serum potassium level. Do your diligent assessment about the patient's ability to swallow safely. Also check for their bowel sounds, if it's active, if not active, if it's absent, do not give the medication. Notify the physician because possibly this can cause necrosis of the bowel, which can perforate, possibly leading to another complication. So those are your nursing care. And also monitor for the patient's bowel movement. Usually it is expected that the patient will be passing stool probably about 4 or 6 hours after the administration, and do another check of the potassium level to see if there is improvement. Okay. Now, again, the reason why this is given, it's because of letter B. That is the answer, to swap potassium ions for sodium ions. So the kayaksilate itself, it's actually sodium polyestyrene, right? So it has sodium in it. Supposing I'm just gonna draw here. This is just assuming the intestine, right? Or the large bowel. And so probably the medication has already reached the large bowel, or let's say the small intestine. So I'll put here kayaksilate. And again, it has sodium in it. So what it does is basically to cause the exchange of the sodium. So through the capillaries here, I'm just gonna draw here tiny blood vessels, capillaries, microcirculation. And so the kayaksilate will cause the exchange of the sodium ions to go into the vascular compartment, whereas it can cause the shifting of the potassium ions from the blood vessels into the intestine. Okay, so when this happens, the potassium ions will now be pooped. It will now be joined with the stools. All right, and this is going to be pooped by the person who took the medication. So again, make sure that the patient has active bowel sounds before administering this medication. All right, now letter C, to lower high phosphate levels. Immediately remove that one because this is not the indication of the kayaksilate. What is given here for a hyperphosphatemia, this condition is actually going to be treated by the use of the phosphate binders. Okay? Phosphate binders. So the medication will be given orally and it will bind to the phosphorus containing food items, and this is going to allow the excretion of the phosphorus through the GI tract. Okay, now if you probably have forgotten those phosphate binders, we have them as the Renvela, 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 or known as the Renagel, or another name called Phosrenal. Phosrenal. So these are your examples of phosphate binders. Okay. So the kayaksilate doesn't do any binding to the phosphorus at all. No, it's only going to cause the exchange of the sodium and the potassium ions in the gut. Now, for the letter D, to relieve constipation from the sorbitol. Incorrect. Because the sorbitol can actually be used with a kayaksilate, but this is not the primary purpose of the drug. Now, if going back into letter A here, before I will forget for letter A, to correct acid-base imbalances. So in this case, when the patient goes into a metabolic acidosis, there is going to be a drop in the blood pH. Could be less than 7.35, right? Because it's acidotic. So our problem here is that it can cause so many issues into the patient's neurofunction. It can also cause problems with the excretion of the hydrogen ions and also the its effect in the vascular system. Okay, so in order to resolve this metabolic acidosis, then we are going to expect the medication called sodium bicarbonate, which is often given as IV in a case of metabolic acidosis. Sodium bicarbonate. And again, this is given IV. It could be in the form of a slow IV push, or it could be administered as a piggyback, or let's say an infusion, for about maybe 30 minutes in some instances. It depends on the pharmacy protocol. And so you have to deal with that. And also, you're going to have to monitor for the pH after the administration of that medication. And again, this is just not limited. The metabolic acidosis is just not limited to the pH. It can also cause problems to the heart tissue, right? It can cause excitability of the heart muscles. And so let me just put it in here. Hang on, let me erase this. So for the metabolic acidosis, so this is going to just review what we had talked about. Metabolic acidosis with the pH being low, pH that is low, sodium bicarbonate. All right, let me just write it out. I'm tempted to write the abbreviation, which I'm not supposed to do. Okay, sodium bicarbonate. That's another thing, guys. We are not gonna, it would not be safe to actually write those medication names in abbreviations. And that is one of the guidelines by the Joint Commission. Sodium bicarbonate. Always write the complete words with the medications. The abbreviations are not widely acceptable anymore because of the medication errors that have occurred. So sodium bicarbonate, that is for the metabolic acidosis. With the hyperkalemia, because this is intended for the hyperkalemia, right? With a metabolic acidosis, excitability of the heart tissue. So if there is excitability, hyperexcitability of the myocardium, wherein it can develop into excitability. If the myocardium or the heart cells are quite excited, then this can lead into the cardiac dysrhythmias. So our treatment here is to give the patient the calcium gluconate. Okay? Calcium gluconate. This is going to be administered either slow IV push and also could be an IV infusion. Okay? Again, this is IV. And guys, when your patient is manifesting the hyperkalemia metabolic acidosis, most often our patient needs to be monitored continuously, cardiac monitoring. Okay? Yeah, you don't want to miss the life-threatening cardiac rhythm. So we want to make sure that we're able to follow through of what is currently going on with the patient. We want to see if there's any deadly arrhythmias. So make sure that our patient is connected to the heart monitor. Of course, if this is not ordered by the doctor, we can obtain an order to have that established. Okay? It doesn't mean that it's not ordered, that there's nothing you can do about it. You can do something about it. Call for an order for cardiac monitoring, and that would help you to find out if there's any life-threatening cardiac dysrhythmias. Again, for the excitability, calcium gluconate will be given as an IV push, slow of a push, or it could be an infusion. And then for the hyperkalemia, let me just put K plus, elevated, that is the kayexalate. Okay. And there's also that temporary treatment, which is basically the dextrose 50, okay, plus the regular insulin. Remember, I mentioned about this in our acute renal failure, chronic renal failure discussion. The reason why we are pushing D50 with a regular insulin, it is to cause what? We want to allow the migration of the excess potassium ions. Let me put the blood vessel here. So if there is hyperkalemia, when we are giving the D50 plus the insulin, regular insulin, this can temporarily displace the potassium ions from the bloodstream because it's really high, right? And we don't want way too much of the potassium in the bloodstream. We want to at least temporarily stabilize the body by causing the potassium ions to migrate into the cells, okay? So again, this is temporary treatment for about 6 hours. So the potassium will stay inside the cell, right? Only for about 6 hours because of the regular insulin's action. It lasts for about 5 to 6 hours, right? So potentially, if there is no follow-up treatment, there's no iaxylate, there's no dialysis that's going to be done to the patient with the renal failure, eventually these potassium ions can go back into the blood vessels. So back to where it began, okay? So that's why it's just not about D50 insulin injection or the calcium. We also have to give them the iaxylate and possibly the dialysis to finally get rid of the potassium ions. All right. So again, only 6 hours because that's the action of the regular insulin. All right. And why about the D50? Why is the irregular insulin given with the D50? Well, we don't want the patient to become hypoglycemic during this treatment. And so we have to kind of buffer the hypoglycemic effect of the insulin in order to prevent the hypoglycemia. Now, other than that, for those patients that have hyperkalemia, maybe they still have some EGFR of probably 50, 60, 80 mLs per minute. And so another modality in getting rid of the extra potassium in the bloodstream is the administration of the Lasix, or known as the furosemide. Okay? And this is a loop diuretic, right? So the Lasix, which is going to be given IV, this can readily work. It's very rapid. Within 5 minutes after the administration, or after you had finished giving the Lasix IV, this will cause the diuresis, right? Remember that this is a diuretic that mainly works into the loop of Henle, right? So let's go back into the nephron. Glomerulus, the convoluted, proximal convoluted tubule, the loop of Henle, descending, the loop, the ascending, the distal convoluted tubule, the distal convoluted tubule, and then we have the collecting ducts over here, right? And so the target here for the Lasix, the furosemide, it will target the loop of Henle. Because this is where most of the reabsorption of the water and also the reabsorption of the sodium takes place. Okay, even though there's also reabsorption in the proximal convoluted tubule, but most of its target is located into the loop of Henle. Even though it can also cause prevention of the reabsorption in the other kidney tubules, but its main target is in the loop. That's why it is what we call as loop diuretic. Now again, if it's given IV, it can readily act within 5 minutes. All right. So this is now going to cause the excretion of sodium, not just the sodium, there's water, and also the potassium ions, and even calcium and the rest of the electrolytes, chloride. So the potassium is not the only electrolyte that is being excreted by the Lasix, but the other electrolytes as well. All right. So remember about the Lasix, calcium gluconate. There's also the kayaksalate, sodium bicarb. All right. So these are your drug cocktail in the treatment of metabolic acidosis and hyperkalemia in renal failure. Now, in some practices, though it's not really mentioned nowadays in the med-surg books, but it might come out in the exam, we also have the beta adrenergic agonists, okay? Beta 2 adrenergic agonist. Though it's also another treatment that can also help in the hyperkalemia. Let me erase this. Beta adrenergic agonists such as like albuterol. So why is the albuterol going to work in the hyperkalemia? Well, what it can do is actually to temporarily cause shifting of the potassium ions from the blood vessels into the cells. It can cause temporary shifting, okay? So again, it's not really as popular as before, but just in case, it might come out in the exam. So again, our possible treatment, the sodium bicarbonate, calcium gluconate, the kayaksalate, Lasix, and also the beta-2 adrenergic agonist. But again, and also the insulin and D50. But don't forget about the dialysis, which would really help out in getting rid of those excess ions. All right, so I hope that you're able to understand now if you were kind of like clouded in the previous lecture. So our focus here in this test item is to make sure you know the mechanism of the medication. Yes, you do. It takes time to understand and you have to be patient with yourself, okay? Don't be too hard on yourself if you have a hard time understanding the drug action. You have to really go back on it if you are confused, okay? Read some more other simplified versions of the explanation until you can understand, okay? That is very important, especially when we are talking about manifestations that you need to watch for, let's say side effects. So you have to engage yourself to go back into the concepts in pharmacology. Now, another tip here is to eliminate those unrelated effects, such as the acid-base balance. No, kayaksalate doesn't cause the neutralization. Okay? It doesn't cause the blood pH to become neutral, such as 7.35 to 7.45. It doesn't have that effect. Only the sodium bicarbonate. Okay? Because the sodium bicarbonate is what we call as the alkalinizing agent. All right? Now, also you need to match the drug to the specific condition. And also, again, we are talking about the kayaksalate, which is primarily used to what? Cause the excretion of potassium ions in the GI tract, in the large bowel, by allowing the person to poop. Okay? So if you're gonna recall, if you're gonna remember about the kayaksalate, think about pooping. Okay? Think about stools. All right? I hope that helps. All right, moving on to the next item. A patient with severe left lower back pain, nausea, vomiting, and restlessness shows signs of pallor and sweating. His vitals are blood pressure of 145/85 mmHg, pulse of 112 beats per minute, respirations 30 breaths per minute, and temperature 97 degrees Fahrenheit. Which symptom most strongly suggests kidney stones? Again, a patient with severe left lower back pain, nausea, vomiting, and restlessness shows signs of pallor and sweating. His vital signs are blood pressure of 145/85, pulse rate of 112 beats per minute, respirations 30 breaths per minute, and temperature 97 degrees Fahrenheit. Which symptom most strongly suggests kidney stones? All right, let's go through the options. A, previous mild flu-like symptoms? Or is it B, vomiting with a coffee ground appearance? Or C, pain radiating to the left upper abdomen? Or D, dark colored urine with low volume? All right, take your pick. All right, let's go through the options. If you had selected letter A, previous mild flu-like symptoms, this is incorrect because this is not specific to kidney stones. Not specific. There's different conditions that can manifest as flu-like symptoms. And we are being asked about symptom most strongly suggesting kidney stones. That is the clue here. So disregard all of those options that can be easily associated with the other conditions. And so, yeah, eliminate that. Now, go back into the chart here. Patient has severe left lower back pain, and because of that, there's nausea and vomiting and restlessness. And there's now pallor, sweating. That's a sympathetic nervous system response. The blood pressure is high, 145 over 85. That's abnormal. Pulse that is tachycardic, 112. Respirations high as well. The patient seems like she or he is panting for catching their breath. So look into the associations of these manifestations. There is much more of like increasing sympathetic nervous system response with the pain, elevation of the heart rate, blood pressure, respirations. We have a temperature of 97. The temperature is not a problem at this time. So A has been eliminated. What about B? Vomiting with a coffee ground appearance. Remember that when we are talking about coffee ground appearance, this is going to pertain about gastrointestinal bleeding, right? Right. Okay. So we're going to cross this off as well because it doesn't relate to the kidney stones. Now, what about letter C? Pain radiating to the upper or left upper abdomen. This is something that can be associated with other conditions as well. And this is not going to be specific to the kidney stones. So remember, guys, that when I said about the kidney stones, the pattern of the pain when it appears actually starts from the flank area, right? And it kind of mimics the movement of the stone when the kidney stone is passed from the upper section of the urinary tract. When the stone kind of migrates, goes down from the upper to the middle to the lower section of the ureter. Lucky, right? If the patient's stone is smaller, that it can go down to the bladder. But if in case the stone can get blocked into the ureter, it gets stuck into the junction where the ureter gets so narrow. So the pattern of the pain here starts from the flank area and it is going to radiate. Eraser. It is going to radiate to the lower portion of the abdomen. So guys, don't forget about the characteristic about the pain in renal stone. It radiates, okay? It radiates from the flank, and also it will eventually go down to the lower abdomen and then the groin. Lower ABD and then to the groin area. So quite so different with the type of pain in pyelonephritis. Remember about the pyelonephritis? We were talking about localization of the pain. It doesn't affect the other side or the other kidney that is not infected. It is going to stay in that section. So if the infected kidney is on the right side, the flank pain will be localized into the right kidney. It doesn't go to the left side, right? So this is quite different. I mean, that's the difference between the kidney stones and also the other type of pain in the renal problems, because here there is radiation. Now, going into letter D, dark colored urine with low volume. Do you think that is the correct answer? Is it the correct answer? Yeah? Okay. This is actually the correct answer. Dark colored urine with low volume. Why? It is because the hematuria has already, it signifies that the stone has already kind of eroded into the soft tissues, especially the lining inside the urinary tract, the lower urinary tract section, maybe the ureter. There are going to be erosion, possibly by the struvite stones. So it will cause that bleeding into that tissue. And also with the urine volume, because there is blockage of the urine flow in those areas, then you're going to expect that there is a reduction in the urinary output. Okay, so we are going to pick this as our correct answer. Right? All righty. Again, our goal in this test question for the scale, we have to look for those distractors, easy to spot distractors, those manifestations that do not really correlate strictly with the renal calculi. So remove those non-specific symptoms and also make sure that you recall the pathophysiology. Okay. Again, renal stones. So the features again is hematuria, gross hematuria, where you can actually see the blood. Let me just erase this section. So the feature of the renal calculi is hematuria. And to add to that, there's also radiating pain, radiating flank pain, and it can also cause lower abdominal pain, but it doesn't get stuck there. It will radiate also into the groin area. So it's not going to stop just right there, but also going to possibly lead to groin pain. Again, radiating type of pain, hematuria, and there's that discoloration of the urine. And again, the low urine output, low UO, low urine output because of the blockage. All right. So those are the three main manifestations that you should recall in the renal stones. All right. Now let's move on into the next test question here. The nurse is creating a care plan for a kidney transplant patient at risk for infection. Which goal is appropriate? Again, the nurse is creating a care plan for a kidney transplant patient at risk for infection. Which goal is appropriate? Is it A, resume regular fluid intake within 48 to 72 hours? Or B, maintain normal body temperature with infection-free cultures? Or C, return to work within 2 to 3 weeks post-surgery? Or D, gradually stop using cyclosporin as quickly as possible? All right. So we are talking about a patient who had a kidney transplant. So you are the nurse creating a care plan for this patient. So which goal is appropriate for this patient? All right, let's go through the selections. A, resume regular fluid intake within 48 to 72 hours. Okay. That is incorrect, right? What we're actually going to promote here is to basically okay, I'm not just going to reveal for now yet. All right. So we can actually promote this, but it's not really the main goal at this point. It's not the primary goal. All right. So I'm crossing this off right now. I'm just going to put good intervention, but not primary goal. Well, with this time though, the patient is going to be on the IV infusion as well. And so that's going to be part of the treatment. And for letter B, maintain normal body temperature with infection-free cultures. And remember, guys, that our patient is receiving a foreign body, transplanted donor kidney, all right? And remember about the mechanics about before the patient gets the transplant. Remember about the pre-medication wherein the patient will be taking that anti-rejection medication to prevent the body to reject the new organ or the kidney, right? And so at this point, this patient is actually going to be prone to developing the infection, opportunistic infection, not just because of the incision, the surgical procedure, that's part of it, the incision itself, but the immunosuppressant medication that has been taken already can also lead to the opportunistic infections to occur in this patient post-op. So our goal here is to maintain a normal body temperature with infection-free cultures, right? That is the goal. What about letter C? Return to work within 2 to 3 weeks post-surgery. Well, this is somewhat kind of, I would probably say 50-50. There is a possibility in the patient to go back to work within the time frame, but take into consideration that the recovery can vary from one person to the next. And so the other reason that it's going to be an incorrect answer is because it's not quite related to infection control, right? Because we are being asked about risk of infection, right? What about letter D? Gradually stop using the cyclosporin as quickly as possible. Now, let's do a quick review about the cyclosporin. This is an immunosuppressant. It can suppress the patient's system from attacking the donor kidney. All right? So we are not going to teach a patient to stop using the cyclosporin. The patient will be needing that medication for their lifetime. All right? Without the immunosuppressant medication, the patient will start rejecting the donor kidney. So there is no need to gradually stop this medication as quickly as possible. So we are left with the only correct answer, which is letter B. Maintain normal body temperature and infection-free cultures. Guys, remember when I mentioned about the signs of rejection? There's that hyperacute rejection. There's also the acute. The hyperacute tissue rejection actually happens within hours during the transplantation, okay? The acute can happen within months to years. And there's also that chronic rejection, which can happen in 1 to 2 years. So take a look here. There's different levels, hyperacute, acute, and chronic. And remember, in hyperacute, or even in the other levels like acute and chronic, the patient will have elevation of the temperature as well. There is hyperthermia. There's also high blood pressure, increased blood pressure. And also manifestations of infection, inflammation, drainage from the wound. So those are the things that we need to keep an eye out on this patient that just received a kidney transplant, okay? Look into the effects of the medication itself. It can really cause suppression of their immune system, but at this point, Yeah, in this question, we are focusing on the infection, but we have to kind of look into the other factors that could possibly be involved in this test question, right? Alrighty. So we are going to move into the next test question here, which is about peritoneal dialysis. During peritoneal dialysis, the nurse notices that the return fluid is draining slower than usual. What should be the nurse's immediate action to address this issue? Is it A, position the patient's bed in reverse Trendelenburg, or B, check the outflow tubing for kinks or blockages, or is it C, encourage the patient to cough, or letter D, elevate the drainage bag above the patient's abdomen? The question again states, during peritoneal dialysis, the nurse notices that the return fluid is draining slower than usual. What should be the nurse's immediate action to address this issue? Is it A, position the patient's bed in reverse Trendelenburg, or B, check the outflow tubing for kinks or blockages, or C, encourage the patient to cough, or D, elevate the patient's abdomen? All right, hope that you have selected your answer. Now, letter A, position the patient's bed in reverse Trendelenburg. We're talking about a patient with peritoneal dialysis. Remember about this topic? Yeah, if you have forgotten about this, then I encourage you to go back into that recorded video talking about peritoneal dialysis. All right, I want you to. Now, the issue in this scenario is that there is slow than usual drainage. Okay, that's not a good sign. If there is slow drainage, something probably has caused that one. Okay, and so what would be your action in order to resolve the slow drainage? So if this is your patient's bed, okay, and then if you're going to put the patient in the reverse Trendelenburg position, reverse Trendelenburg position basically is going to allow like an angle wherein the bed will be slanted, right, with the head of bed right here and the foot part. So it's kind of diagonal with the head of bed elevated. It's not like one of those like high Fowler's position like that, but the reverse Trendelenburg is pretty much like that. Okay, slanted with the body, of course. There's no like flexing or whatever in the trunk. This is something that is going to be possible, but not the first step for the nurse to do to resolve. Okay, it might be a good intervention, but a first step must take first. Okay, before positioning this patient into a reverse Trendelenburg. Okay, please don't get confused, right? Because Trendelenburg's position is actually the head lower than, or let's say, let me erase that. The Trendelenburg's position is basically the head is going to be lower than the legs or the lower extremities or the trunk. So that's the Trendelenburg's position. So when we're talking about reverse, that's exactly the opposite. And so when we are putting them in the reverse Trendelenburg, yes, that can help. But again, it's not the priority nursing action. What you should be doing here is to what? Do the checking of the outflow tubing and checking for any blockages. Always do the troubleshooting. Look into the kinks. Maybe there is clamping and untoward clamping of the tubing. So you do that first, okay, before you do the other procedures. Now, what about letter C? Encourage the patient to cough. Yes, it can be also an alternative, but again, you start with checking the kinks or blockages. What about letter D? Elevate the drainage above the drainage bag above the patient's abdomen. Well, isn't that kind of scary when you're actually causing infection to the patient? Remember that the drainage bag is contaminated, right? You don't want anything from the drainage bag to go back into the patient's abdomen. So for example, this is our patient in bed. We have our IV pole right there. So after or when we are instilling the dialysate into the patient's abdomen, okay, it will allow to mix with the abdominal fluid, so it will be allowed to dwell for some time. But when there is that drainage phase, there should be a some kind of a gravity that can allow the drainage of the fluid coming from the patient's abdomen into the urinary bag. Okay, so the urinary bag should be placed lower than the patient's body, especially lower than the abdomen, because if you're going to lift this bag higher than the abdomen, it can allow those effluent. It can go back into the tubing and can cause some infection into the patient's abdomen, leading to peritonitis. We don't want that. Okay, so eliminate letter D. Not a good answer. Not a good answer. Not a good answer. Okay, so we're going to check first for any kinks and blockages. So after that, you have done that, then probably you're going to have to allow the patient to change their position from one side first and wait for the movement of the drainage, and then try to reposition the patient to another side, or to put the head of bed elevated as well, or have the patient do some coughing. It might dislodge those fibrin, what do you call this? Fibrin, those fibrin type of clots. Okay, so we want to make sure that these are displaced in order to allow drainage. Okay, so our test taking skill here is to definitely start with the simple solution: assessment. Check for the most obvious and easily correctable problem first. Okay, do that inspection. Now you also need to eliminate those less direct interventions. The positioning can be good, but after that you have done your inspection. Okay. Now moving to the next question here. Number 9, in the assessment process for the potential transition to continuous peritoneal dialysis, what fundamental requirement must a patient meet to be deemed eligible for this treatment approach? Again, in the assessment process for potential transition to continuous peritoneal dialysis, what fundamental requirement must the patient meet to be deemed eligible for this treatment approach? We're talking about peritoneal dialysis here. What is that requirement for this patient in order that they can avail this kind of treatment modality? Is it A, fully healed vascular access, or B, severe fluid accumulation in the lungs, or is it C, stable hemodynamic status, or D, documented failure of hemodialysis? All right, I hope you had picked your answers. Or answer, letter A, fully healed vascular access device. What is that? Well, this is not going to be a requirement because it is not associated with peritoneal dialysis. This is associated with hemodialysis. Okay? Remember that with hemodialysis, when the patient is going to have that permanent device, such as the AV fistula, this is going to be created in order for this patient to be able to have the dialysis, hemodialysis. This fistula is going to require about 6 to 8 weeks of maturation. Okay? The maturation will take that long. So if the patient really requires an immediate hemodialysis, maybe because of the metabolic acidosis, hyperkalemia, and other physiologic manifestations, then there should be another way of doing it by the use of the hemodialysis catheter, which is going to be available. Okay, so an immediate insertion of a hemodialysis catheter. This is possible in order that the patient can undergo the cleansing of the blood, the filtration. But again, if the medical provider thinks that this patient probably will gonna need hemodialysis in their lifetime, then there's that AV fistula creation. It is a surgical procedure in order that the patient will be able to use this for long-term hemodialysis. And this is something that is not applicable to peritoneal dialysis. Remember that the peritoneal dialysis is going to involve with the placement of that access device that's not going to involve blood vessel. So it's going to create that hole, incision, and placement of that port in order for the catheter to get advanced during the peritoneal dialysis. It doesn't require maturation at all. Okay, so we are eliminating letter A. What about letter B? Severe fluid accumulation in the lungs. This is incorrect because this is going to indicate immediate intervention, but it's not going to be a criteria for peritoneal dialysis, right? It's not. What about letter C? Stable hemodynamic status. Yes, this is what is required for the patient in order that they can tolerate peritoneal dialysis. Okay? Question is again asking what fundamental requirement must the patient meet to be deemed eligible for this treatment approach? They need to be stable hemodynamically. Okay? Right? Because this is going to involve the instillation, the infusion of the dialysate into the abdomen for that particular amount of fluid. And if they're not stable enough to tolerate that, they could probably go into different issues during the treatment. So that should not be indicated for those patients. Now, for letter D, documented, let me just mark here as a check for letter C, documented failure of hemodialysis. It's not really required. It's not a primary requirement in order for the patient to transition from hemodialysis to peritoneal dialysis. It's not. So we are crossing that one. That's false information. So our strategy here for this question is to basically identify the fundamental physiological requirement for this patient, make sure that we understand the basic health condition, especially needed for the peritoneal dialysis. And another thing is we're going to have to eliminate those relevant option or less relevant, I should say. So like the A, fully healed vascular access device, again, that's not going to be required. And also the documentation of failure from the dialysis, hemodialysis, also letter B, right? Too many distractors. Now let's move on to the next item here, which is item number 10. During hemodialysis, which action should be taken to prevent complications related to an arteriovenous fistula in the arm? Again, during hemodialysis, which action should be taken to prevent complications related to an arteriovenous fistula in the arm? Is it A, notify the medical provider if you notice a bruit and thrill over the fistula, or B, ensure IV lines are inserted away from the fistula, or C, refrain from taking blood pressure readings on the fistula, or D, check the pulses distal to the fistula regularly? Okay? Take your pick. Okay. So our situation here is on a patient undergoing hemodialysis. So we are asked to identify what nursing action should be taken to prevent complications related to the AV fistula in the arm. If you had answered letter A, notify the medical provider if you notice a bruit or thrill over the fistula, immediately cross that, because that is the expected finding. Thrill and Brewy. You always will be checking this one before, after the dialysis. Why? We want to maintain the integrity of the fistula to check if there's any clotting or any problems, maybe bleeding. Always do the check. So when you are feeling for the thrill, or you can also auscultate the Brewy, okay? That swooshing sound that you can actually hear through the auscultation. So that is expected finding. Nothing to worry about this. It doesn't need notification to the medical provider. What about B? Ensure IV lines are inserted away from the fistula. This is wrong because it's only saying away. It didn't say the arm, the other arm that has not the fistula. So away could mean that you're allowed to put an IV access into that same arm with a fistula, which is a big no-no. We don't want that. So no venipuncture, no blood draw. There should be no IV insertion. There should be no what do you call this? Compression of that arm. Let's say checking the blood pressure. No BP measurement. Because with a BP measurement, you are actually causing compression of that arm with that blood pressure cuff. So no blood pressure measurement, no application of tourniquet, because this can compress the blood flow and it can possibly lead to the disturbance into the fistula. It can possibly cause clotting. And that's why we have to put a sign on the doorway, or let's say the overhead part of the patient's bed. No venipuncture, no IV insertion, no BP measurement in the IV or in the AV fistula site. Okay. So again, the B is incorrect because it's only saying away. It should not say that. It should state no IV insertion, no venipuncture, no BP measurement in the arm with the fistula. Okay. Letter C, refrain from taking blood pressure readings on the fistula arm. This is what we were this is the information that we wanted. But again, always do by elimination up until you can find the answer. So that's letter C. What about D? Check the pulses distal to the fistula site regularly. Yes, that's also a good nursing intervention. You need to check that integrity of the fistula site. But again, what we are asked here is to prevent complications related to the AV fistula. Okay? Preventing the complication is the question. We are not, this is not really a preventive action. Okay? I mean, it can be preventive, but not as like as immediate, right? And so we are eliminating letter D as well. Okay. Now we're going to move into the next item here, which is this question. When a patient with end-stage renal disease exhibits frequent premature ventricular contractions on a cardiac monitor, what should the nurse do first? All right. A mix of cardiovascular, my favorite. When a patient with end-stage renal disease exhibits frequent premature ventricular contractions on a cardiac monitor, what should the nurse do first? Is it A, get ready for possible defibrillation, or B, administer intravenous diltiazem, or is it C, check the latest potassium lab results, or D, contact the healthcare provider immediately? All right. So when the patient, oh, what happened? Okay, it looks like our question is erroneous, so let me just correct that really quick. Okay, so our, let me change that real quick here. Hang tight. History. Here you go. Basically, copy that. Okay, here we go. So the question again said, when a patient with end-stage renal disease exhibits frequent PVCs or premature ventricular contractions on a cardiac monitor, what should the nurse do first? Is it A, get ready for possible defibrillation, or B, administer intravenous diltiazem, or C, check the latest potassium lab, or D, contact the healthcare provider immediately? So we're talking about the patient with end-stage renal disease with frequent PVC. PVCs are something that I don't like because they can be a precursor of another dysrhythmia. It could lead into VTAC or ventricular tachycardia, or it can lead into much more problem like VFib. We don't want that. Okay, so what you should do here in order to properly deal with this patient with a PVC, and it said frequent. Maybe a PVC that's only going to occur maybe once in a minute. That is somewhat kind of on the safe side. But let's say if you are seeing the cardiac monitor with frequency, let's say 5 PVCs in a series. Yeah, that's not good. 5 PVCs in a series is already considered as a ventricular tachycardia. This is something that you need to report to the physician right away. Okay? It only said frequent. It didn't say how many. All right? So we don't have any information in the passage. We don't. And so what should the nurse do first? Get ready for possible defibrillation. Is it appropriate at this time? Do you really need to defibrillate the patient just because of the frequent PVCs? Is it required? No. This is incorrect. Why? Because defibrillation is only reserved for life-threatening arrhythmias like VFib, okay, which is basically the quivering of the ventricle. Okay, this is not intended for this situation yet. Defibrillation, again, is only indicated for the life-threatening arrhythmias such as the VFib, ventricular fibrillation, or could be the pulseless ventricular tachycardia. Let me write that down. VFib and also pulseless VTAC. So these are the two indications for the application of the defibrillator. But at this point, we are not supposed to do that yet. What about letter B? Administer intravenous diltiazem. What is this medication? Diltiazem is a calcium channel blocker. Just put in here CCB. Calcium channel blocker. And this is going to be used for rate control. Of course, I'm talking about the heart rate. And it is going to treat atrial arrhythmias. Atrial arrhythmias. And the CCB, diltiazem, is also used in some other disorders like angina pectoris, or it can also be used as an antihypertensive medication. But in this scenario, it is one of the options to treat the PVC. Okay. Now remember, guys, this is only intended for atrial arrhythmias. The situation is talking about ventricular arrhythmia, premature ventricular. It's not indicated. Eliminate that one right away. Okay? What about letter C? Check the latest potassium lab results. Yes, of course. That is correct. Why? Because we want to investigate if the patient's potassium level is very high in a case of hyperkalemia. And again, the PVCs is going to be the one of the major complications of hyperkalemia. A plus PVCs. If not treated, it can lead to VFib. It can also lead to pulseless VTAC. And again, it varies because we have different varying levels of the hyperkalemia, which I will be showing in the next slide. And so you have to be careful, make sure that you have to review the patient's lab results. How bad is the hyperkalemia is, okay? Good thing that's only saying frequent PVCs, but we still need to investigate. Is it frequent PVCs like 5 in a series, or is it like PVCs that's kind of intermittent? Because 5 in a series is much worse than having 4 or 5 that's not really continuous. So for D, contact the healthcare provider immediately. Do you have to really call the doctor right away before investigating further? Of course not. And so you're gonna eliminate letter D as well. You can contact the medical provider if you have done your assessment findings, if you need maybe some orders. Let's say if there is no lab result, for example, if there is no retrievable potassium level for this patient, then definitely you have to call the doctor. Doctor, I don't have any baseline information for this patient's potassium. Would you be able to give me an order to do a stat blood draw to check for the potassium? Yes, in that case, that's correct. But in most scenarios here, especially, we definitely need to check into the investigation first, which is basically assessing the latest potassium level, which is letter C, okay? Now, I'm going to show you right here the different levels of the hyperkalemia. So, showing you right now the first configurations here with the regular potassium level of 5 milliequivalents per liter. That's within the normal range. Okay, so you can find the PQRST waveforms. All right, looks kind of perfect to me. But 5, yeah, it's normal. But on the upper edge, the T wave is in the normal state. The P wave, it's okay. There's no disappearance of the P wave. But here, when you are looking into the potassium level of 7, now you are going to start seeing the T wave right here. Okay, let me just tip. You are now seeing the T wave when there is going to be a elevation of the potassium, K 7 milliequivalents per liter. So basically, when we're talking about the T wave, this is representing the repolarization of the ventricles. Okay, when I'm talking about repolarization, this is the time that the ventricles will start to relax. Okay, that's what it's called, repolarization. However, in the case of hyperkalemia, when there is tenting T wave, elevation of the T wave, this is now becoming a problem wherein the amplitude of the T is so high. Look at the difference here compared to a potassium level of 7. There is now an elevation, an amplitude of T is elevated. So it suggests that the ventricles are repolarizing more vigorously or rapidly than usual. That's the reason why there is tall, tented peak T waves. Again, it suggests that the ventricles are repolarizing more vigorously or rapidly than usual. Now, looking into the potassium level of 8 milliequivalents, all right? So you will see now that there is absence of the P wave. Compare it to the previous EKG. There is P wave here, but it's starting to decline or disappear. But here, at this point, you cannot see the P wave anymore. in the potassium level of 8. So there is now a disconnection between the P waves and the QRS complexes, which is basically here. There's no more P wave. So there is now disconnection between the P wave and the QRS complex. So that is very significant. When you don't see the P wave anymore. Okay. So with a high potassium level, with let's say potassium level of 8, basically it can also affect the heart's conduction system. So it can possibly impact the AV node, which is basically right here, represented by your QRS, right? That's your AV node. Let me erase that. So there is now dissociation between the atria and the QRS, right? So there is now, let's say, a gap between the P wave and also the QRS complex in a potassium level of 8. Again, this is what we call as dissociation or disconnection between the P and the QRS complex. Now, talking about the potassium level of 10, look into the transition here from an 8 to a 10. There's no more P wave. The T is much higher this time. And now there is elevation. You don't like that image. So the QRS complex, it looks much broader. Look at that. There is now lengthening of the EKG here. And this can now be one of those serious stages that it can potentially lead to the dangerous heart rhythms like VTAC or let's say fibrillation, right? So you got to be careful when you see a patient with a potassium of 10. No, you don't want to sit and enjoy yourself in the nurse's station this time and charting. No, you have to call the doctor right after you have done your diligent nursing assessment. If there is no order yet for treating this hyperkalemia, then call the doctor right away. If the patient is becoming symptomatic, let's say there is now VTAC, and the patient is manifesting so many more clinical features, hemodynamic instability, all the rapid response, okay? That could help you out in dealing with this patient, especially if you're probably not familiar with the patient. You probably just stepped in your shift after getting the report from the previous shift nurse. And once you stepped into the patient's room, oh my God, what is going on with my patient? Or maybe you are in the ER. So you really have to catch this pretty soon. Now, with this, moving forward here, with that potassium level of 10 milliequivalents per liter, again, the QRS complexes are much more, they are irregular and much wider, okay? Get ready for those VTAC and fibrillation to occur, okay? You've got to get ready with the crash cart, the defibrillator. Make sure that it's accessible, because potentially patient can lead to that. But it's not time yet to defibrillate the patient. What about potassium level of 11? 11 potassium level is much worse. This is going to give you this image wherein it says biphasic waveforms. So this is really reflecting that there is significant alteration in the cardiac conduction system because of the hyperkalemia. And so this is much more advanced level of hyperkalemia, again, much more serious cardiac dysrhythmias. Your patient can probably go into the VFib in this situation, okay? So definitely you need to immediately do your diligent care for this patient. Make sure that you're treating the hyperkalemia. And again, recall those medications that I said earlier. What are those medications? Calcium gluconate, Lasix, furosemide. We also have the sodium bicarbonate to alkalinize the pH of the blood, okay? And then following that, we can give the kayexalate, all right? Again, calcium gluconate in order to stabilize the myocardium. You know why this is going on here? All these weird life-threatening cardiac rhythms? It's because the heart cells are so irritated, so hyper-excited. And so our goal of treatment here is to make sure we deliver the calcium gluconate, okay? And cause the shifting of the potassium ions from the bloodstream to the cells. We're going to give insulin, regular insulin IV plus the D50 to cause shifting of the potassium from the blood vessels to the cell. Also give the sodium bicarbonate IV to neutralize the blood pH, which is acidic, and also to administer, what else? Did I say Lasix already? Yes, to promote excretion of the excess potassium ions in the bloodstream. All right, so those are your immediate nursing treatment. And then followed by the kayexalate, okay? And then succeedingly, if there's an order for the hemodialysis, then get ready for that procedure as well. All right, so I hope that you're learning much more with this diagram. So if in case your patient probably proceeds to the 12 milliequivalents per liter of potassium, I don't want to be the nurse. No, just kidding. No, just in case you're going to deal with this kind of patient, especially if you're the ER nurse receiving the patient from the nursing home with this high of a potassium level. Yeah, look at that. I don't like this rhythm. That's already VFib. And so potentially your patient now have the pulseless fibrillation, ventricular fibrillation. There is now cessation of the cardiac activity. Your patient needs to be defibrillated right away. Okay? Defibrillate. Defibrillate. Okay? Defibrillate your patient this time. All right. So that's it. We're going to have to talk about this kind of topic in the cardiovascular. But let's get moving to the next question here. For a post-op patient after pyeloplasty, which symptoms should prompt suspicion of acute renal failure? Is it A, urine output below 400 mL in the past 24 hours? Or B, nausea and vomiting? Or C, frequent bowel movements? Or D, no urine output at all? Question is, for a post-op patient after pyeloplasty, which symptoms should prompt suspicion of acute renal failure? Is it A, urine output below 400 ml in the past 24 hours, past 24 hours rather, or B, nausea and vomiting, or C, frequent bowel movements, or D, no urine output at all? Let's go through the selections here. What about letter A? Urine output below 400 mLs in the past 24 hours. I don't like this. I don't like that. So this is already considered as oliguria. Okay? Any urine output that is less than 400 mLs in 24 hours, or let's say less than 20 mLs per hour. That is also considered as oliguria. Less than 20 mLs per hour or less than 400 mLs in the past 24 hours. That is oliguria. Meaning there is a reduction in the urine output. As we know, normal expected, right, is minimum of 30 mLs to about 50 or 60 mLs per hour. Okay, I'll just put 60 there. That is expected hourly urinary output. Anything below 20, that is oliguria. Okay, this is a hallmark for acute renal failure or acute kidney injury. And in the context of this situation, pyeloplasty, your patient is post-op. The oliguria here could signify that the patient might have a post-op ischemia. There is low blood supply to the kidney. Or maybe an injury to the renal parenchyma, to the kidney. right? So this is very important for us to make sure that we are detecting. So I don't want you to wait for exact 24 hours in order that you're going to take action. No, you have to really watch your patient even during the first 2, 3, or 4 hours post-op. Don't wait that it's going to be 6 hours, just like with that kind of scenario that we went over in the past session, that the nurse was dealing with a post-cholecystectomy patient, and the patient only had about 100 mLs of urine for the 6-hour period after the surgery. That's crazy. And so it's really important that you have to keep an eye into the urinary output. As soon as you receive the patient, make sure that you ask the nurse who gave you this patient, how was the urine output in this patient previously? Was it within the acceptable range, or was it in the safe range? So that you can anticipate what could possibly a complication for this scenario, right? And make sure that even during the first hour, keep an eye into the urine output, because if there is low urine output, there's not even a passage. Maybe there's some kind of an obstruction in the catheter, but something that you need to do really is to investigate why there is why is this going to be low urine output? Was it because of massive blood loss? Or maybe the patient is not getting IV fluid post-op? Yucks. So that is not going to be a good scenario, all right? So make sure you do your hourly urinary checking immediately. Make sure that you can capture this one. Now, what about letter B? Nausea and vomiting. We're being asked about which symptom should prompt suspicion of acute renal failure. Nausea and vomiting, these are non-specific manifestations, and they're not really quite associated with post-op conditions. So we're going to eliminate this one. What about letter C, frequent bowel movements? Is there frequency in the bowel movements with acute renal failure? No, there's no relationship with that. So it doesn't really provide us relevant information about the renal status as well. So we're going to eliminate this. And what about D, no urine output at all? Well, that is anuria. No more urine coming out from the kidney. Anuria. Again, go back to the question. We are being asked for a patient's status, that you had a suspicion about acute renal failure, the onset of acute renal failure. Remember about the different phases? We have the oliguric, which is gonna happen very suddenly, and then this is gonna happen for probably days, and then this is going to be followed by the diuretic phase. Another phase that you need to be careful about, wherein the patient will have polyuria. They're going to be losing way too much fluid in their system. They're going to end up dehydrated if you're not addressing. And then lastly, the recovery phase. So don't forget about the phases of the ARF, oliguric, diuretic, and recovery phases. But again, we are being asked about the acute renal failure, especially for a post-op. Okay. So our answer here is letter A, no, or there is urine output below 400 mLs in the past 24 hours. That is our answer. So for the test taking scale here, you need to recall those signs of the renal complications specific to the patient's recent surgery. Again, look for that oliguria, which is the first sign of acute kidney injury. Okay, that is the critical symptom to monitor. All right, let's move on to the next question. A patient describes leaking urine when coughing, sneezing, or lifting heavy items. What type of urinary incontinence does this suggest? Is it A, reflex incontinence, or B, overflow incontinence, or C, stress incontinence, or D, urge incontinence? It didn't really specify what gender this is. Is this a male or female? No, Is this an elderly person? No. So we're only going to have to give the answer to identify the type of urinary incontinence. All right. So there is leaking when the patient coughs, when he or she sneezes, or when lifting heavy objects. So let's take a look at letter A. So I really want you to continue answering in the comment section here, guys, so we can track if you're really participating. So I would really appreciate that. So reflex incontinence, what is this? Well, this is incorrect. Mark that right away, because the involuntary loss of the urine without any warning, typically to neurological impairment, this is not going to match the patient's description of the leakage during the physical insertion. Okay, so that is wrong. What about letter B? Overflow incontinence. Well, this is going to be characterized by the bladder's inability to empty properly. And this is going to end up with dribbling. Okay, so this is associated with urinary retention, chronic urinary retention, I should say, and it also does not correlate with leakage because of the physical activities. So this is going to be wrong. So again, overflow incontinence is dribbling because of chronic retention, chronic related to chronic retention. Okay. And for A, the reflex incontinence. So this is basically, reflex is a urological impairment. So there is involuntary loss of urine without warning, neurological impairment. All righty. All right, let's move on to letter C, stress incontinence. Is this going to be the correct option? Stress incontinence is actually the correct answer here. Why? Because this is going to involve the urine leakage during any physical activity that can cause the increase in the intra-abdominal pressure. Let's say when the person coughs, or when they sneeze, or when they are lifting heavy objects. Okay? So again, stress incontinence is associated with increased intra-abdominal pressure. So associated with those, heavy lifting, coughing, and sneezing. Right? What about letter D? Urge incontinence. The urge incontinence actually is going to be a sudden, it's like intense urge to urinate, and this will be followed by involuntary urine loss. And so this is mostly associated with the overactive bladder. Overactive bladder. Or we call that as the OAB. Okay? Overactive bladder, that is the association with the urge incontinence. Right? So it doesn't really match with the question that we are being asked. All right, so I hope that you're learning about the different types of incontinence. Okay? Let's move on into the next test question here. For a patient with oliguric renal failure, what is the expected 24-hour urinary output? We're back to the numbers. Is it A, less than 100 mLs? Or is it B, less than 400 mLs? Or C, less than 600 mLs? Or D, less than 1,200 mLs? Okay. Again, the question states, for a patient with oliguric renal failure, what is the expected 24-hour urine output? We already answered this in the previous scenario. So if you had answered letter A, less than 100 mLs, that is incorrect. This is already considered as anuria. Please take note, guys. Anything that is less than 100 in the 24-hour period is already considered anuria. This is much more severe than oliguria. So the patient's kidney has this shutdown, renal shutdown. This is much more advanced. It's much more critical than the oliguria, because when the kidneys is no longer working, those metabolic, the waste products, the BUN, the creatinine, the uremic, toxic products, the potassium, magnesium, those electrolytes that are supposed to be excreted by the kidney are no longer going to be excreted. So there will be buildup of these electrolytes in the blood. And so it can cause elevation of these numbers and could lead to a whole lot of complications. Could be metabolic acidosis, some hemodynamic disturbances, could be cardiac dysrhythmias. Okay. What about letter B, less than 400 mLs? Remember that we talked about this. This is the correct option. Okay. Oliguria, again, that is 400 mLs per 24 hours or less than 20 mLs per hour. That is also considered as oliguria. Now, about less than 600, what is that? Well, 600 is still a whole lot. It's not even going to be under the category of oliguria. So there is less level of, there is some kind of an impairment already going on. But again, this is kind of like much, I should say, less problematic compared to the oliguria. Okay. Now, what about letter D? Less than 1,200 mLs. This is within the normal or expected range. So nothing to worry about letter D. Eliminate this, eliminate this as well, and eliminate letter A because that is anuria. Again, go back into the concept about the urinary output of less than 400 mLs. Okay. Now, let's move on to the next question. When a patient is diagnosed with benign prostatic hypertrophy, which test is used to monitor the disease progression? Is it A, prostate-specific antigen or the PSA, or B, complete blood count, or C, calcium levels in the blood, or D, creatinine levels in the blood? The question is about a patient diagnosed with BPH, and we are asked about what test is used to monitor the disease progression. Is it A, PSA, or B, CBC, C, calcium levels in the blood, D, creatinine levels in the blood? Okay, take your pick. All right. Well, if you answered letter A, prostate-specific antigen, this is the correct answer, because the level will actually become a direct indicator of the prostate's activity, and this is also going to be used to monitor the progression of the BPH. And aside from monitoring the progression of the BPH, this is also going to be the lab test to determine the progression of the prostate cancer. And so, again, if there is PSA elevation, this is going to be associated with BPH or prostate cancer. Now for letter B, complete blood count. Is this going to monitor the disease progression? No. Cross that out. This is only going to help in the diagnosis of, let's say, anemia, or it could be infection to check on the white blood cells, but not about the benign prostatic hypertrophy. Now, taking a look into the calcium levels in the blood, do you think so? That is one of the diagnostic tests? Not really. It's going to be an incorrect option because this is going to be checked if there is an electrolyte imbalance suspicion, or let's say, for example, if there is a suspicion that there is metastasis into the bone tissues. So this is not going to be that diagnostic test. Remove that. What about letter D, creatinine levels in the blood? Well, that is also incorrect because the serum creatinine can indicate that kidney function problem, or it could be an obstruction due to an enlargement of the prostate gland, but it does not track the benign prostatic hypertrophy, or let's say the progression of the BPH. Okay, so I really want you to go back into the diagnostic tools for the specific conditions. I actually created those notes way back, in the previous lecture, so I want you to review those if you failed to answer this one correctly. So what your goal here is to eliminate those tests that do not directly relate to the disease that we are talking about. Okay. Now we're gonna take a look into the last question here. When instructing a patient with uric acid kidney stones at discharge, what dietary advice should be emphasized to avoid? Is it A, low calcium, or B, low oxalate, or C, high oxalate, or D, high purine? The question states, when instructing a patient with uric acid kidney stones at discharge, what dietary advice should be emphasized to avoid? Let's go through the answers here. A, low calcium. This is incorrect. Why? Because this diet is actually going to be important for reducing the risk of calcium oxalate stones, not uric acid. Okay. What about letter B? Low oxalate. This is also incorrect because a low oxalate diet can help manage calcium oxalate stones by reducing the oxalate levels in the blood, but it's not going to be specific to address the uric acid stones. That's why this is incorrect. But what about letter C? High oxalate. Again, consuming high levels of oxalate can also increase the formation of calcium oxalate stones. So not the uric acid stone. So you're going to eliminate this. So we are left with just one option, letter D, high purine diet. So we know that those high purine foods such as organ meats increased uric acid production, and this can also lead to the uric acid stone formation. So we're going to have to select the high purine as the food items that should be avoided. Okay. So again, what are your test strategies here? You have to make sure identify first the kind of stones the patient is presenting with. Okay, identify that first. Now, once we have identified the kind of stone, then we are going to eliminate those choices that are not going to be related to the uric acid stone formation. Okay, so that's pretty much it. Our discussion ends here. And so thank you so much for your attendance today, and I hope that you're learning. And again, we are encouraging you to like and subscribe this video, and also share this with your friends who are trying to pass their NCLEX exam. We'll be announcing some more about the future classes that we're going to have. All right, so give us a thumbs up, and also put in your comments if you have any questions about our classes.